ain't never work out, Nia.
Do you know who I am?
I know. I said your name. I know who you are.
Nia Long, get it, nigga. What? That's right, girl. I told you. When he get on, he gonna leave your ass for a white girl. What, you want a Barbie? What about all of this? You just want some What about the ass?
Them to have that at VA. We've developed in partnership with DoD military competence training for providers. It provides up to 8 hours of continuing medical education free for community providers or internally, for people to be able to understand the language and about taking a military history. We've also lobbied to have a CPT code added for taking a military history, which is part of a reimbursement mechanism in the private sector, so that people will be encouraged and financially rewarded for doing that.
Okay, thank you. Dr. Berger, I'd like to ask you a question about research, and I think we all agree there needs to be more research. You said that about 70% of veteran suicides are people of the age, among males, is people of the age 50 and older, and according to your chart, 85% of male veteran suicides are age 40 or older.
Well, sir.
So my question is, let's say Vietnam era veterans who served 40 to 50 years ago, in this, let's say between 65 and 75, 1965 and 1975, tell us about the connection between that service and a suicide at the age of 70 or something like that. And I understand probably every suicide is for unique and personal reasons, but what does research tell us about the connection there?
Well, certainly, excuse me, sir, there are risk factors that all veterans share. There's no denying it. But at the same time, as we age, there may be additional risk factors added to the pool. For example, in the case of our older vets, it may involve insurance, health insurance kinds of things, if they're not enrolled in the VA in particular. There may be family issues that surface at that time. The structure in our lives changes. But at the same time, I'm not aware of any focused gerontological research on these different aged cohorts and which risk factors may be important at particular points in time.
Thank you, and I appreciate the work of every one of you on the panel. Our hearts go out to those who have committed suicide at whatever age, and so thank you for your preventative work. Mr. Chairman, I yield back.
Thank you, Mr. Lamborn. Ms. Brownlee, you're recognized.
Thank you, Mr. Chairman, and I wanted to thank Dr. Mafucci for bringing up the Female Veteran Suicide Prevention Act, and I am encouraging all of you to help in supporting this bill. We have a companion bill in the Senate, and I certainly would like to see this particular piece of legislation see it through, because I think the focus, although Dr. Berger talked about, I believe you talked about an increase in being able to treat women veterans, I think it's really critically important that the VA is the expert, the absolute expert in this issue around suicide, and particularly looking at best practices for both our male and female veterans, because I do think a female experience on the battlefield can be very different from a man's experience. So thank you for that. I also, wanted to talk a little bit about outreach, and I know that we have a transitional program to have a warm handoff when our veterans leave the service from the DoD to the VA, and I think that that's positive. I'm curious to know how well that's going and what it looks like, but I think we have to actually dig back further. In other words, it seems to me we should have medical professionals on the battlefield. There. I think in terms of outreach with family members, I think we need to, for a veteran who is sent to the battlefield, who is potentially going to experience trauma, the family members should be trained and prepared. So on their reentry back, the family members need to know. And when we talk about older veterans, which for the first time today, I'm aware that the suicide rate amongst older veterans are going up. We've got to figure out some kind of outreach in those cases as well. But I do think that I think we train our men and women to go to the battlefield and be prepared to save their physicality and their physical health, but we also need to prepare them to survive their mental health as well. And so I think we have to go further back, starting really at the beginning, so that people are knowledgeable and aware, and even the veteran can be aware of their own behaviors and help themselves. So I guess the question that I would like to answer, or to get some answers from, is really how this handoff situation from the DoD to the VA is really working. How do these handoffs take place? What are they looking like? And are we collecting some data on that to figure out if this kind of warm handoff is actually working? I open it up to anyone.
So we're kind of looking at who might do this.
All right, I'll jump right in here, at least from the perspective of what I know about it. VVA has stayed away from using the term seamless transition because there is no such thing. I would only point out we have many, many cases where the transfer, quite frankly, there's no other way to say it, is screwed up, and it ends in the result, focusing on today's topic, in a veteran suicide. For example, I'm sure you've all heard there's at least 2 or 3 cases in the last year or so of vets who were prescribed certain kinds of medication in DOD for their mental health challenges. They get to the outside, those records weren't forwarded to the VA, or there was some kind of barrier or what have you. The VA gives a diagnosis, puts them on perhaps another complete set of mental health medications, and they can't cope, and they take their own lives.
Dr. McCarthy, do you have any responses in terms of that response and how you believe the program is working, and if what Dr. Berger is saying is true, how do we rectify that?
So I'll be happy to respond to the medication parts, and I'll turn it over to Dr. Thompson about the program, if that's okay. Thanks, Tom, for bringing that up. We have had an opportunity to look very closely in our cross-agency partnerships about this particular transition time and medications. And we have made it now so that all psychiatric and pain meds that would be prescribed in DOD could be prescribed in VA. And it is our expectation that those the medications would continue seamlessly. However, the expectation is that the provider would do a safety review. So if, for instance, there are multiple drugs of the same class and too many, that at that point they could be adjusted. But the expectation clearly is that this go well. We've done 2 sets of chart reviews, actually looking at specifically transitioning veterans. Of 1,000 veterans that we checked, I believe the number was 20 that had a medication change that was not what we expected it to be. That's 20 too many. And so we've provided feedback to those providers who made that change. We've also increased our education program specifically about meds. But I'd like Caitlin to talk about the transition program.
Well, my time has run out, but maybe we can follow up. I yield back, Mr. Chairman.
Thank you, Dr. Rowe.
I'll yield my time to answer the question.
Thank you, sir. So we also have what's called the In Transition program, which is a coaching model so that service members who have difficulties with mental health are given a coach while they're still in service, who then help them and make sure that they have that transition point across to the VA. But we really take all of this extremely seriously, especially because we know, and for older veterans, but also for others, that those veterans who are going through transition in any way are at very high vulnerability for suicide risk.
Okay, thank you. I want to start by, first of all, thanking the VA. I think you all have, I think you do have the largest comprehensive mental health program in the United States. And it's not perfect, but it's certainly better than it was 7 years ago. When I first got here 7.5 years ago, there's no question the focus that the Congress has given and the VA has given has improved things. One of the things that's hard to do in suicide, and first of all, as a practicing physician, was to identify those people who are at risk, because it's a silent demon that you carry around you don't share with anyone. And I think one of the things that we've learned today is that when patients, veterans do get into care at the VA, their suicide rate goes down. I think we have figured that out. Number two, I think we've also learned that the hiring process at the VA is ridiculously long and should be shortened for not just mental health, but other providers of health care. I think that's got to be shortened. And I don't know what takes so long. I've hired multiple physicians in my career, and it doesn't take that long. It's not that hard to do your background checks and so forth to find out what you need. I think the other thing that has been brought up, and what is confusing about this, is when you look at the data, and I think the cohorts of people are different. For instance, us guys, Vietnam era guys, that's a different cohort than the younger veterans that are leaving. And when you look at the suicide data from 2001 to 7, non-deployed veterans had suicide rates higher than deployed veterans, which is confusing for us. The fact that why does that happen? So I think more research is important, and I think one of the things that we have to do, family and friends, and there is no question. I looked at data years ago when I was in practice that showed that somebody who went to a psychiatrist had a higher rate of suicide than somebody talked to their best buddy. So having a good friend to talk to, and having someone, and you pointed out very clearly, I think you need to expand this program where you can touch a buddy that was in the service. Those of us who served have a different look at things, a view of the world, and so forth. And when you have somebody that's been down, that has put their overalls on just like you have, it makes a big difference. And I think that's a program that works, and it should be expanded. The other thing I want to encourage you to do at VA and outside the VA is get good data, because without that you can't make the right decisions. You just cannot, and you can't group us all into one big group. We're different. You got to look at different cohorts with female, younger veterans, and older veterans like I am. So I'll stop there and let anyone make a comment.
So maybe I could mention the data analysis that's going on right now, because we're excited about this. This is very different from what we did in the past, where we had to get data from the states, and some states gave us data and some did not. We have worked with CDC and with DOD and have requested data on everybody that had been in the military or the VA between 1979 and 2015. And so we sent multiple discs with data that could be matched with the CDC data for suicide. And it's coming back to us. It's very raw. It involves a lot of individual checking and so forth. We so wanted to have the data to share with you at the hearing. We don't. We were told that it would be analyzed by the middle of the summer, and we promise we'll get to you as soon as we can. But we're really excited because this is not state-specific, and it crosses ages, sexes, and all those other kinds of risk factors that we really want to be able to identify. And we want to make that data available to our academic partners in a transparent way so others can help us understand.
Two things that was said, and Dr. Berger pointed it out, that this 22, you're just saying 22, well, that is probably not correct, because if you look, it was just 21 states, it probably isn't correct, and yet that's quoted all the time. That's why we need accurate data. And in the U.S., we're 50th in the world in suicide, and I'm proud of the fact that we're really pointing out, because it all comes down to one person. Look at all this data. It doesn't matter when you're the one person, the one patient out there, the one veteran or civilian that's contemplating taking their life. It's preventable. It's just like opioid addiction and deaths. Those are preventable deaths if we pay attention. I yield back, Mr. Chairman.
Thank you very much, Ms. Custer. You're recognized.
Thank you very much, Mr. Chair, and thank you, Dr. Rowe, for setting up my comments on the opioids, because as I sit and listen, and by the way, this is one of the best panels I've heard since we've been here, but as I sit and listen, there are so many corollaries. I'm a co-chair of the bipartisan congressional task force to combat the heroin epidemic. And we now have over 80 bipartisan members, and we're passing 15 bills this week. And I want to commend my colleagues on both sides of the aisle and Jackie Walorski for her work on veterans. We were passed yesterday the Promise Act. But there's so many corollaries, and many of the same people. 4 out of 5 heroin users have a co-occurring mental health disorder, often undiagnosed and untreated. But I wanted to speak to you particularly, Ms. Ricocchio. I'm sorry. First of all, my condolences for your loss, but thank you for your courage. And a big part of this is about stigma. It's about mental health generally and the stigma around mental health. So one piece I want to convey to you is that we want to help you to be a leader on addressing stigma, and particularly for veterans. In New Hampshire, I'm very proud of a new program that we have that's called Ask the Question, and we're using this across the state. This is way beyond the veteran community. This is our entire healthcare community, mental health community, every person that comes in contact with anyone who comes before them, to ask the question, did you ever serve? My father was a World War II pilot. He was shot down. He was a POW for 6 months. No one ever asked him this question. He never talked about it till he was well into his 70s, and it was only when my boys growing up started asking him all the questions. What was the plane like? What happened to you? What do you mean? What happened after you hit to the ground? Tell this story. So I'm curious about this peer support, because this is what one of my communities has just started for heroin use. Yeah. And it turns out that incredible psychological bond of someone who's been before you. And if you could talk more about how can we help you to grow that program, and then just generally for any of the witnesses, how can any of us here help with the stigma and the support? And then just lastly, really want to commend a candidate, and I don't mean this to be partisan. To be honest, I don't even know his party. But this is in yesterday's Politico, one candidate's risky bet talking about his PTSD. He's running in Delaware, and he's a veteran. And it is a risky bet, but the courage for you as a family member to come forward and for others to come forward, I think is critical.
So thank you so much. And I'm from Massachusetts, so I'm aware of that campaign, and it's a great campaign. And we actually have all been speaking together, like Caitlin and I work a lot together on messaging with the Department of Defense. And one thing we've really talked about is there is a need for all of us as a whole to change the messaging around the VA and around suicide.
Good.
That number 22 that's been going around, we had a suicide in the veteran population about 5 months ago who left a suicide note, and in the suicide note said, I'm going to be one of the 22 today. Why should I even try? So having the negative messages out there that it's an epidemic, that there's 22 dying a day, is increasing hopelessness in our veteran population, and the feeling of helplessness and the feeling that treatment doesn't work. It is the biggest barrier to them getting real good treatment with the demons that they're bringing with us from unresolved early childhood trauma, and additional combat-related issues. So I think we need a campaign where we're all speaking with one voice that about the people that are getting treatment, that treatment works, that more people are getting treatment and surviving than are dying by suicide. So that we can get those veterans out there really thinking, you know what, there's others that have gone through this, they've survived it, and they're doing well, because we have amazing veterans in our communities that are doing unbelievable work. And we have peer-based programs all over the country, like Red, White, and Blue and Team Rubicon, that are pulling these veterans together, are providing hope, and are real beacons of who these veterans really are. Who they're loyal, and they're smart, and they're dedicated. And so we've got to start a campaign that looks at that and talks about that, and stop focusing on the fact of how many have died. We've raised the awareness. We know it's a problem. Let's get in forums like this and fix the problem, but at the same time get a message going out there that treatment works, and it doesn't have to be that way. So I think that's
my
really
time is up. I'm sorry, we'll have to come back on another round, but I would just say I saw the other night on television this Invictus that's going on this week with the sports, and so powerful, the hidden wounds of war. And this is part of what we're going through in the addiction community. Is anonymity has been such a big part of this, which is important for treatment, but for those on the other side to come out and start to tell their story is so powerful. So thank you so much for being with us.
Thank you very much. Dr. Benishek, you're recognized.
Thank you, Mr. Chairman. I too would like to thank you all for being here this morning. I just want to follow up on something with Dr. McCarthy that's been bugging me since I've been around here. And I don't know, I mean, is it emblematic of what's going on? Is it a sign of the sincerity of the VA? But I have an issue with when you call the VA hospital and there's an automated message that says, dial 1 for the pharmacy, dial 2 for the outpatient clinic, dial 3 for OR, but if you have a mental health crisis, please hang up and dial a 10-digit number, okay? Well, this is a pet peeve of mine, all right? And I have been working on this, and now in my district, they fix that, all right? Because I've been on it all the time. But as of this morning, in Michigan, the Iron Mountain VA and the Saginaw VA have fixed it, but there's still three medical centers in Michigan that you have to hang up and dial an 800 number. Now, I brought this up in committee a long time ago, and I'm asking why this is not fixed. And they said, well, it'll all be fixed in 6 months. Well, that was more than 6 months ago. And I'd like to know why we just can't fix this right now. Why does this change take so long? So you agree it should be fixed, right?
Oh, sir.
Is there anybody?
I have good news. You want some good news? There are 12 VAs where you can press 1 and get directly connected from the medical center. 12 to the crisis line.
That's what I'm telling you. That's not very many.
Hawaii and a few other places, which is pretty great in terms of the technology. It's not all of them, and it should be all of them, and that is clearly in the works. And
you see, this is why I bring this up, okay? Because to me, this is something that should be just fixed automatically without taking a year to do it, all right? So here we are talking about mental health crisis, all right? And you can't do this. You understand what I'm saying? We got all kinds of huge problems to solve in dealing with mental health patients, and you can't fix this? It is outrageous. I mean, I'm amazed by this. I mean, it hurts me because these are blocking and tackling. This is solving the individual problems that veterans have when calling. This is a crucial thing. I mean, I've had individuals talk to me about this very problem, you know, and they try to kill themselves in the parking lot of the VA because they couldn't get help. So what I'm trying to tell you, my comment here is that this is a blocking, tackling, minor thing that these are the kind of things you got to fix every day and not take a year to do it. So you're telling me that there's only 12 places in the country that this is actually occurring out of the hundreds of VA facilities around?
It's my understanding it was 12 the last time I checked. I know that it's rolling out really quickly.
Is there somebody within the VA that's resisting this change that you're aware of?
Oh, no. We have a rather old phone system, and we have a number of challenges with it. But
Well,
I'm
don't
not
do that.
doing
You got the dial 1 for the pharmacy. It connects to the pharmacy just fine.
okay.
You know what I mean? So don't
right.
blame it on the phone system. Here's the other thing I want to know. When you dial this crisis line, I mean, a lot of people end up dialing the crisis line because that's the only place they get a person, right? So what is the process for triaging people that call the crisis line who may not actually be in a mental health crisis, but they're just trying desperately to talk to somebody at the VA?
So let me let Dr. Thompson take that call because she's worked it.
Thank you, sir. These are such important points, and I do want to. By the end of the summer, all of the VAs will have rolled out the Press 7, so that those Press 7 numbers get to the Veterans Crisis Line. The reason that they have to pilot it is because they have to know how many people will be available at the crisis line as they roll this out. Otherwise, there won't be enough people to answer.
So
those calls.
right now you're saying the 800 number, there's nobody there?
I'm sorry, sir?
No, sir. No.
Your answer makes me suggest that you're not rolling it out because you don't have people behind the scenes to do it.
No, we have to. There's just you have to pilot things in order to understand what the rollout's going to be. But I assure you that by the end of the summer, all VAs will be rolled out. But we absolutely understand.
That was what you said
and
last
your
year.
Concerns. This has taken longer than we had thought, and
We personally tested it, and
What about the question I just asked? About the
Yes, sir. So when people, and I worked in the crisis line for 5 years, when people call the crisis line, there is a set of questions to ensure that the person isn't at immediate risk and they need somebody right away, which happens 30 to 40 times a day, where somebody needs that immediate help because they're in the process of dying by suicide. They can't commit to being safe. So,
How many questions is it?
It varies as far as there are certainly like a few questions that are important for a suicide risk assessment.
How long does it take?
To do a suicide risk assessment?
On the phone, yeah.
The immediate question is are you safe right now, really? And that's an immediate question. And then there needs to be developed a rapport with the person who is calling. So many of the people that call, this is the first time they've called.
I'm out of time.
Before.
Thank you.
I would glad to give you some more if you need it.
And I'm happy to keep answering the question, but
Well, unfortunately, I don't know your answers or what he's looking for.
It doesn't
to talk about a silly pilot on something as serious as this is just ridiculous. Mr. O'Rourke.
Thank you, Mr. Chairman. And Mr. Chairman, I'd like to begin by thanking you for bringing much needed attention and focus and accountability to this issue. I can't think of a more important issue for us to be working on. And I think that's reflected in your leadership. And I would just ask that we continue to keep the pressure and the focus and our commitment to provide the resources and the oversight necessary to make progress on this issue. And I think to a person, we're all there with you and the ranking member to maintain this as a priority. And I want to thank everyone who's part of the panel today from the VA and from the advocate community for your help and focus, the information that you're bringing to this so that we can make better decisions, so that we can hold ourselves and the VA accountable for making improvements. And I want to echo the ranking member's suggestion that through you, Dr. McCarthy, this goes to the Secretary. He has 12 wonderful priorities for transformation of the VA. Not one of them is specific to reducing veteran suicide. And I authored a letter that the ranking member, Republicans and Democrats, signed asking for just that. I'd hate to have to do that legislatively. I think that's something that the Secretary can do and should do, and we'll ask him through you to do just that. Until it is a stated priority, we're not going to see the changes that we need to see. We're not going to prioritize prevention. We're not going to move from pilot programs to full implementation of necessary interventions. I just believe in that wholeheartedly, and it needs to happen. And if we need to get the veterans advocate community behind that, to create the political pressure and will to do that, then so be it. But let's not have to do that. One of the questions I have is whether, if we'll just use 22 as our baseline statistic, 22 veterans a day taking their lives. If 17 of those veterans are not accessing VA care, and if we believe that if they were to have accessed VA care, the outcomes would have been better, Dr. McCarthy, is the VA ready today in terms of capacity, number of providers, space, other considerations to see those 17 veterans?
That's a very thoughtful question. What we've tried to do with the 17 is find other ways to have us reach out to them. And so we have this suite of mobile applications. We've worked on helping providers treat them and so forth. Space is a challenge.
So let me ask this, because I was really looking for a yes or no, and it sounds like the answer